Tukakade, and I'm back with my new video. In the earlier session, we have discussed about how to evaluate a case of breast lump. Now, this is a short session where we will be discussing how to stage a disease of breast cancer. So, till now, just imagine that you are a surgeon and you have a patient, a female who have come up to you. She is 40-year-old female coming to you with a breast lump. So what you have done, you have done a clinical examination which has been followed by, being a 40-year-old female, you have done mammography that has shown suspicion of malignancy, and after that you have done a true cut biopsy. This true cut biopsy has told that this is a malignant cancer, malignant lesion, that is a cancerous lesion. So now what you need to do, we are going to do something called as staging of cancer. That means how far is the malignancy grown, whether it is related to that breast, or it has metastasized via lymph nodes, or it has gone to somewhere else as a distant metastasis. So that we are going to see. So let's see what we do under staging. But before that, let's see about certain basics related to that. So first thing is, who gives you the staging? So the staging has been given by the AJCC 8th edition. Okay, there are different editions which are given. So this is the American Journal of Cancer and its committee. So that is the AJCC, and according to its recent 8th edition is the staging protocol. So now what they say is, before making a final conclusion of stage, you need to add a certain prefix, right? If you are using a prefix C, okay, so if you are using a prefix that is C, this is going to be a clinical staging. That means you have done clinical examination and based on that you have done your staging. This is the clinical staging. If you are using a prefix R, this means this is a radiological staging. If you are using a prefix P, this means this is a pathological staging. And a very important thing that has been asked recently in FMG as well as AIMS, that is, what if you are using a prefix Y? If you are using a prefix Y before any staging, this means that the patient has received neoadjuvant chemotherapy. That means before the surgery or before this staging, this patient has received chemotherapy, and after chemotherapy you have staged. So now in your scenario that I have given to you an example, you have done clinical examination, you have done um, radiological investigation as well as pathological investigation. So overall, whichever staging you are going to do, chiefly you are going to apply the prefix C, because that will be the main component for investigating, right? So before investigation, suppose you have done just a clinical examination, you will put as C. I'll give you an example. We are going to see a staging, but let's see, I'll give you an example. If you have done a clinical examination and stage comes out to be T4, yes, if it comes out to be T4B, then what it will be called as, the stage will be called as CT4B. If you have done a radiological investigation and it says that it is T1C, then that will be written as RT1C. These are the examples that I am giving you, right? If you have done a pathological investigation and it comes out to be an inflammatory cancer, that will become T4D, then it will be staged as PT4D. Understood? This is how you are going to do. This is how a staging is written. Now let's see about the staging. So as per the AJCC, 8th edition, we are going to discuss the Tnm staging. So now what is this Tnm staging? Further also, when I'll be teaching different cancers in surgery, we are most of the time using the Tnm staging. So what is this basically? TNM. So T stand for tumor size, N stands for nodal status. Nodal status means what is the status of the lymph nodes, and M means metastasis. That means a spread to a distant organ. That will be TNM. So now let's discuss about the TNM staging. So let's start with the T staging first. So what is T1? T1, before the T1 there is TIS. TIS means it is an in situ malignancy, right? It is an in situ malignancy. That means suppose they have done a histopathological investigation. This was the basement membrane. These are the cells above which look to be malignant, but the basement membrane is intact. The basement membrane is intact. This is what is called. This is what is called as a in situ malignancy. If it is a T1. If it is T1, it will be less than or equal to 2 centimeters. T1 will be less than or equal to 2 centimeters. Now stage T1 is further classified. Stage T1 is further classified as T1A, T1B, T1C. Okay. Now what is T1A? T1A is zero point 0.1 to zero point 0.5 centimeters. T1B is zero point 0.5 to 1 centimeters, and 1C is 1 to 2 centimeters. Now let me remind you, what does T means? T means tumor size. So now if I say that there is a lump whose size is 1 centimeters, it will be staged as T1B, right? That will be T1B. Then you have T2. Now T2 is very simple. It will be 2 to 5 centimeters, whereas T3 will be more than 5 centimeters. That will be T2 and T3. So if I have a lump of 5 centimeters, it will be staged as stage T2. Now something very important coming up is T4. Now T4 is very important. It is divided into A, B, C and D. So now T4A, T4B, T4C and T4D. What are these? Now T4A is nothing but a tumor of any size with chest wall involvement. Yes, so clinically, how will you elicit that there is a chest wall involvement? Very simple. Let me make it clear by putting up a hashtag here. Okay, very important that pectoral muscles not included. So even if the lesion, even if the mass or the tumor is involving the pectoralis major or pectoralis minor muscle, that will not be considered as a chest wall involvement. So chest wall involvement will be only the involvement of ribs and the intercostal muscles. Now how will you elicit that? You'll ask the patient to sit properly, and you will ask the patient to bend forwards. After the patient bend forwards, you are going to observe the patient from lateral side. During examining laterally, when the patient bends, normally what should happen, both the breasts should fall forwards. But if there is a lesion in a breast, say suppose in a left outer quadrant of of the left breast, I mean, if there is a lesion which is involving, that is, it is encroaching or is invading over the chest wall, that is the rib cage and the intercostal muscles, what will happen when the patient bends forwards? The right breast, that is a normal breast, will fall, but the left breast will remain in an upward position. It will not fall more. So there will not be a symmetric falling of the breast. But this is how you will identify that there is a chest wall involvement. Right? Next, stage 4B will be any size with skin involvement. Now, in the first class itself of the breast, we have discussed about skin involvement. So, what things are to be considered for skin involvement? The things that have to be considered for skin involvement, I mean, are pseudo-orange appearance. Then you have an ulcer and satellite nodules. Now here I would like to put up a mark with the same color, that for stage 4B, please remember that tethering and puckering and nipple retraction are not included. These three are not included. Okay, these are not to be included. Why? Because these are look like a skin involvement, but these are not true skin involvements. These are nothing but involvement of the your tethering and puckering is nothing but involvement of ligament of Cooper, whereas your nipple retraction is an involvement of lactiferous duct. So it is not actually a true skin involvement, and that's why T4B, in that case, you will only consider pseudo-orange appearance, which is orange skin-like appearance because of an obstruction of lymphatics, ulcer, and satellite nodules. Right? Next, when it comes to C, T4C is nothing but a combination of A and B, whereas T4D is inflammatory carcinoma. Okay. Inflammatory carcinoma clinically is identified as, pseudo-orange, but it has to be more than 30% of the breast showing pseudo-orange appearance plus an histopath evidence. And histopath evidence that will tell that this is an inflammatory cancer. So that there is a report that says that the patient is a case of inflammatory carcinoma of breast, you will write it as T4B. That's all about the T staging. Then talking about the N staging. Now N staging, N0 means there is no lymph node involvement. LN means lymph node. Then you have N1, where N1 is ipsilateral mobile axillary lymph nodes. Now at which level? That will be level 1 and 2. In the earlier few videos we have already discussed what is level 1, level 2, level 3. Then we have N2A, which is ipsilateral but fixed axillary. Now it is not mobile, now they have become fixed, so a stage ahead, right? So ipsilateral fixed axillary lymph node of level 1 and 2, right? Level 1 and 2. N2B will be written as ipsilateral, but now it's not axillary, that will become internal mammary group of lymph nodes. Internal mammary lymph nodes without, okay, that is without axillary lymph nodes, that is going to be N2B. N3A will be ipsilateral infraclavicular or apical lymph nodes. Okay, then N3B will be ipsilateral. Now N3B will be something opposite that of N2B. N3B will be ipsilateral internal mammary lymph nodes with axillary lymph nodes. So along with axillary lymph nodes, there is also an ipsilateral internal mammary group of lymph nodes. N3C will be ipsilateral supraclavicular lymph nodes. So let me revise quickly. N0 will be no lymph node involvement. N1 will be same-sided axillary lymph nodes, but these are mobile. They can be moved by your fingers during palpation. N2A will be ipsilateral, that is same side, but now they have become fixed because of a more amount of infiltration by malignant cells. They have become fixed. N2B is, instead of going to axilla, they have come to internal mammary, but axilla is not involved. So internal mammary group of lymph nodes without involvement of axillary, that will be N2B. N3A will be infraclavicular or apical group of lymph nodes. N3B will be internal mammary with axillary group of lymph nodes, and N3C will be supraclavicular group of lymph nodes. This is about the nodal staging. Now let's talk about the M, that is the metastasis, right? M0 means there is no metastasis, and M1 means there is metastasis. Now here comes a very important question. Now the very important question here is that which organs are involved, and there is a lymph node stage which is now considered as metastasis as per AJCC. Now as per AJCC, contralateral axillary is considered, contralateral axillary lymph nodes is considered as M1. That means if there is a lump in the left breast and there is a lymph node positive on the right axilla, that suggests that it is M1 now. And what are the organs that you should check for is vertebrae, especially the lumbar vertebrae, upper lumbar vertebrae, liver, and lungs. These are the three sites where breast metastasis occurs. So this is how you are going to in toto stage a disease of breast.